Good afternoon, and thank you for joining us. My name is Peterson Jamonge. I am the volunteer manager here at the National Patient Advocate Foundation. This afternoon, we will be hearing from Dr. Rachel Grob, who's a good friend of our organization, and she'll be talking about how we can use, and these trainings are usually for volunteers, but we welcome new ones. But Dr. Grob will be talking to us about how we can use patients' experiences to inform and advance our advocacy work. But first, a warm welcome to those joining us for the very first time. I have requested my colleague, who's also the EVP of Patient Advocacy here at NPAF, to give a brief introduction, sort of a summary on the framework and principles behind these trainings, advocacy trainings, and the type of work that we do here at NPAF and at our sister organization, the Patient Advocate Foundation. I'd like to point out that this session is being recorded and will be shared with all of you after the session is over. We will also have an evaluation, so if you have a chance right after the webinar, please give us your feedback. We love to hear back and see what we can do better. We will be reserving the last 10 minutes of this session to answer your questions. And so throughout the session, if you want to type in, there's a chat box to the right of your screen where you can submit your questions, and we'll queue them up, and we will respond to them at the end of the session. Again, thank you for joining us this afternoon, and over to you, Gwen.
Great. Thank you, Peterson. I always have to remember to unmute myself. Good afternoon, everybody. My name is Gwen Darien, and I am very pleased to have you all on our 5th webinar in our series of advocacy training webinars. You can find all of the webinars on our website, npaf.org, and following the webinar, Peterson will send out a direct link to the webinars as well as a link to this current webinar and some follow-up materials. We have been doing a series of webinars which have been ranged from sort of advocacy training to issues training, and there's not such a bright line between the two, but you'll see as you look at what we're doing, how we think about both training on the principles of advocacy and then training about some of the issues that we face. So I am very pleased to have my longtime friend and colleague, Rachel Grob, leading us through this current webinar on using patient experiences. And you are all in for a great webinar. Rachel has been doing phenomenal work around collecting patient experiences in a rigorous research way that is also an incredibly human. It also has an incredibly human quality. So we will be seeing some of the video and hearing about what she's been doing on her newest project. Next slide, Peterson. So we are in the Welcome and Patient Advocacy Program overview. Then I will turn this over to Rachel to talk to you about patients' experiences and how we informed advocacy. Could you go back one? And then we'll do a question and answer. So next slide, please. So I wanted to, for those of you who are longtime advocates, this will be a little bit of a repeat, but for those of you who are new to our organization or new to these webinars, I just wanted to give you a very, very brief overview of Patient Advocate Foundation and National Patient Advocate Foundation, and then what we're doing with the advocacy program. Patient Advocate Foundation is a direct patient services organization, and we provide professional case management services and also some financial assistance to people with chronic, life-threatening, and debilitating illnesses. Most of our patient population is vulnerable and underserved in many different ways in most of our patient population. All of them come to us because they're having trouble accessing quality, affordable health care. We serve a low-income population, a diverse population in all ways, serve a lot of people in rural areas, a lot of people in urban areas, and throughout the country. Our next slide, please. Our National Patient Advocate Foundation is the advocacy affiliate of the Patient Advocate Foundation, the larger organization. And our role is to really take what we learn from the patients that we serve at PAF and the barriers that they are facing and the experiences that they have and their perceptions of the health system and work at changing that in order to better not simply the healthcare experiences, but also the healthcare outcomes. And outcomes, as we know, can mean many things, not just medical outcomes, but also quality of life outcomes for people who interact with our health system. So one of the things that you will see, and you'll see this this incredible connection between what Rachel has been doing and what we're doing is basing and informing all of our work on the experiences and the perceptions of real people as they encounter barriers and issues related to health and healthcare. And what's very important to us, and what is also you will see in Rachel's work, is that we look at what we take our work from what the real people that we serve are encountering. Next slide, please. So our person-centered advocacy, we transcend limitations by breaking down disease boundaries. I'm sorry, I am going to just turn this off. And one of the things that we do at Patient Advocate Foundation, the majority of the people we serve have cancer. However, we serve a lot of people who have cardiovascular disease, diseases around virology, MS, Hep C. We do not serve, the only thing we don't do is that we don't serve people with mental health issues, although many people have multiple issues when they come to multiple health issues when they come to us. We build our advocacy initiatives based on evidence and the data of patient experience. So I have everybody who knows me knows that I have a very serious label making habit, and so my label on my notebook is evidence-based advocacy, and that's what we really try to do is work at turn anecdote into evidence in order to create effective advocacy. So there's a very explicit connection between the community and system change element of advocacy on the one hand and action on behalf of individuals on the other. And that really exemplifies the relationship between PAF and NPAF. Next slide, please. So these are the three parts of advocacy that we identify as the advocacy that we do at Patient Advocate Foundation and National Patient Advocate Foundation. So there are three types of advocacy in our organization. There's the individual, which is the PAF's direct patient services. And not only do our case managers help people resolve their problems, but they also help them how to be advocates as they are going through encounter issues like this in the future, and with complex diseases, people will encounter insurance issues and financial barriers. That they have some self-advocacy resources and skills to help them the next time. We have community advocacy, which is we call advocacy in place, and this is where we empower communities to improve their health and meet the needs of their members locally and regionally. And we have a health equity and community engagement department, which is led by our colleague Shanta Chambers. And at a later webinar, our next webinar, you'll hear about a lot of the community advocacy that we do. And then we have our system change initiatives, which is the primary focus of the NPAF, which is to ensure that the perspective of the individual patient remains central to the governance and policies of the healthcare system. Next slide, please. So our person-centered, this is just an overview of some of the things that we do with our advocates, and I hope that many of you who are who are not yet volunteer advocates for NPAF will consider joining and participating in our projects and our advocacy. So we do training, we do a webinar series, and as I mentioned, this is the 5th in our webinar series. We do in-person training at our National Patient Congress meeting and at meetings, regional meetings throughout the country. We look at principles, responsibilities, ethics of health advocacy, as well as learning how to maximize patient experience, which we're going to learn about today. We do issues education, so the Affordable Care Act, palliative care, Medicare and Medicaid, and then also value models. We have as Peterson is our volunteer manager, and we have an ongoing relationship with our case managers at Patient Advocate Foundation, and we will be doing in the coming year a series of webinars, and their curriculum will help with the case managers at Patient Advocate Foundation will both help determine that curriculum as well as serve as speakers for that curriculum. We have ongoing legislative activities on the state and the national level, and then we also have a lot of partnerships and external opportunities for people who are advocates to be involved with. Next. So I think that this slide I put up as the segue to what Rachel will be hearing from Rachel today, which is how we build on the patient experience. And we look at we define patient-centered health advocacy as working at and changing the boundary between individual experience and collective response. And we know that you can't make things better for an individual without system change, but you also can't change the system without understanding what individual barriers and challenges are. So we work at this intersection. We work as bridge builders or translators, and Rachel and I have been talking about this for a very long time throughout our 15-year dialogue about advocacy and work together about advocacy. But this allows advocates to keep the patient experience center stage, even while we identify consistent patterns among groups of patients. So we have to be very mindful that we both represent multiple patient experiences as advocates, and that our role in many of our activities is to ensure that we keep the patient experience center stage in all of the in the places where we interact and as health advocates. And then we amplify and legitimatize patients' experiences with healthcare and their voice in the public domain. And I think it's really incredibly important to think about the fact that one of our major goals is to really amplify patients' experiences and patients' voices. And one of the ways that we legitimatize patient experiences with healthcare and their voice is by building rigorous evidence and of patient experience and how that impacts and influences and outcomes, and how that can inform our advocacy. So with that quick introduction, and we are very happy to talk to anybody more about our programs and encourage people who haven't to look at past webinars. It is my great pleasure to turn over the webinar to Rachel Grob, who will lead us through work that she has been doing to use patients' experiences to inform advocacy. Thank you very much, and thank you, Rachel.
And thank you, Gwen. That was a beautiful introduction, and I am going to pick up on many of the themes that you touched on, as you might anticipate. So welcome, everybody. I look forward to hearing some of your voices in the Q&A at the end. Meantime, next slide, Peterson, I'm going to tell you just a tiny bit about the center I come from, and then I'm going to get right into the background for, and then most of all, the substance of a particular patient experience initiative we'll be highlighting today. So like many of you, I am about infusing patients' voices into advocacy in order to create a potent tea that will produce better health and better health outcomes for patients. I come from the Center for Patient Partnerships at the University of Wisconsin-Madison. Look us up if you're interested. Next slide, please. And today I'm going to focus on a patient voice infusion process that I hope will contribute to your own advocacy in some really potent ways. And here are some ideas that I have about how it might do so, and I'm hoping we can talk more about it at the end in the Q&A. The grounding of advocacy in patients' experiences, as Gwen already alluded to, is critically important, and in order to do that, we need rigorous approaches to knowing what those experiences are. We are very focused in the patient experience work I'm going to highlight today on what I call the singular importance of having plural voices. We often hear the people who are the loudest. That expression about the squeaky wheel getting the grease can be very apropos in advocacy, but it's our job to make sure that we're seeking out the diverse experiences we know are actually happening out there, and that we focus on variation as well as theme. And then today I'm going to share with you an internet-based patient experience tool that is our way of disseminating research findings from qualitative studies. And this is really important for us as advocates. It's also available directly to everyone, including patients, families, clinicians, the general public, educators, system changers, communities at large. And there's some great evidence about the power of narratives on the internet to improve outcomes and influence people. Next slide. So in the process of becoming rigorous in our approach to understanding what's going on for patients, this movement that again Gwen mentioned, from anecdote to science, has been a critical focus. This is a screenshot of a New England Journal sounding board that some colleagues and I published a couple of years ago. And what we really mean here is that we have a sampling frame that makes sense and is giving us access to those diverse voices and to the quieter voices, that we don't only hear stories that are volunteered, but we elicit those quieter ones, again, in a systematic way, and that we analyze what we're hearing so that we understand both theme and variation. Next slide. One other frame I want to mention, next slide, is this engagement framework many of you may be familiar with, and this is a screenshot from an article that Carmen et al. Published in Health Affairs a few years ago. And this idea of engaging as advocates and as patients and influencing direct care, organizational design and governance, and policy making is, I think, a great way to be thinking about these things. But next slide. There are some gaps in that engagement framework that we're going to be talking about on the webinar today. One is whether we really know what's going on for diverse patients, and the other is what does it take for people who then become spokespeople for system change, like perhaps many of you on this webinar, to be adequately equipped as patient experience experts or ambassadors. And I'm going to talk more about some models for that we've been developing at the end of the webinar. Next slide. All right, so here is the heart of the matter for today. I'm going to talk to you about an initiative for eliciting rich narratives about health and healthcare that's called DIPEX, or a database of patient experience. Next slide. And the reason that partners around the U.S. have banded together to bring this methodology and this initiative here to the U.S. is that it does a great job at a lot of things that we as advocates need to happen. Identifying questions and problems that matter to patients. It's a direct tool for support because of its open access on the internet. It can be used in clinical settings, but also for that organizational change and policy change level that Gwen mentioned. Next slide. How do we go about using this methodology? What does it mean? I'm going to be really brief here, but on the website that I'll point you all to at the end and say for the first time here, it's healthexperiencesUSA.org. There's a Our Methods tab, and people can read a lot more about it there. But very briefly, our aim is to represent that breadth of experience. And the way we go about it is conducting qualitative interviews in people's own home or community setting of their choice. We do that rigorous sampling, we elicit the quiet voices, we videotape the interviews, and we talk to folks until we're not hearing any more new ideas. We look for maximum variation in these stories, and each qualitative research study is on a different topic, and then we create a web-based resource, which I'm going to show you in a second, to go along with it. Next slide. I want to give a lot of credit to our colleagues in the United Kingdom at Oxford who pioneered this methodology, and point out that we are one of now 12 or perhaps even 13 countries who have a major commitment to this methodology and a national initiative to implement it. So we are in very good company and in a wonderful international learning community with this work. Next slide. In the US, we are implementing the DIPEX methodology through a health experiences research network that includes my university, University of Wisconsin-Madison, and Oregon Health and Sciences University, as well as Johns Hopkins and Yale University, and also the VA, which is a national network. And we're working on developing new partnerships, particularly in the South, which, as you can see, is underrepresented so far. Next slide. Here's a brief view of the researchers and patient advocates who are sitting on the steering committee we've had going now for a few years to launch this thing nationally. Next slide. And this is a screenshot of the website I was just mentioning. This is our landing page, and you can see the Our Methods tab up top. Next slide. I'm going to tell you today about the first complete study that our network accomplished and show you a bit about that. But I want to tempt you with the enticing view of what is coming soon, which includes 3 modules focused on cancer in various ways, which I know has been a major focus of the National Patient Advocate Foundation and of Gwen's fantastic work over the years. We also have some studies funded through the VA about experience with war and the aftermath of war and post-traumatic issues. Next slide. So here you can see what we've done so far. We've got 2 studies up on our website, depression in young adults and traumatic brain injury in veterans, which may not quite be live any day now. We've got 4 studies in process, and we've got some more that are already funded. And next slide. You can see our vision for where we want to go from here. Lots and lots of future modules we hope to create, and we invite ideas from you all about it. I'll draw your attention to the cross-cutting topics there at the bottom of the slide. Peterson, go up 1. Thanks. So in addition to focusing on, say, end of life or colon cancer or experiences with diabetes or mental health issues, We, by using a similar methodology, make it possible to look at cross-cutting issues like how do people navigate the health insurance system, or how do poverty and racism affect people's experiences with health and healthcare across the board. Next slide. We've already talked about a lot of these issues at the center of Hearn's commitment. So I'm going to move right on to the next slide and introduce you to our module on young adults' experiences with depression. And please, while you're listening, imagine that this resource will be able to provide similar data on a range of topics. So even if mental health and depression isn't your particular focus as an advocate, think about the power of the methodology. Oh dear. Okay, Peterson, is everything still okay? My screen went blank.
Yeah, I'm going to try that again.
Okay.
Yeah.
All right. Well, meanwhile, I'll tell you a little bit about the study. We had a great team of interprofessional folks working on it. We focused on young adulthood and depression because we feel like there's not a nuanced enough understanding of how depression intersects with that life phase. Why don't you skip 2 ahead, Peterson? Oops. And it's also a critical time of change, which means that what happens to people in terms of their mental health may have particular salience with growing up and changes in your employment status, moving from being a student into adulthood, graduating, etc. Next slide, Peterson.
Yeah, I might have to come back to that. Sorry for that.
Okay, no problem. Can you come down to the next slide? Yeah. Here's just a little bit so you have a feel for our recruitment. We asked people to tell your story to help others, which many people responded to. I think particularly people who are depressed, the feeling that they could be useful to others while also feeling less alone was really powerful. And people have a wonderful experience by and large their story, and I think find it very therapeutic and very empowering. So we've had wonderful ongoing relationships, which I'll talk about a little bit more at the end, with folks who told their story for this patient experience initiative. Next slide. So here is what the website looks like when you get into the module. Right now, we're sort of shifting platforms, but for the moment, it's actually hosted on the UK's site. They have done more than 100 of these studies and have a huge evidence base of patient experience in the form of an archive of about 4,000 interviews, all conducted using a similar methodology. This is our landing page, and we are going to play you now a montage which will give you a feel in the voice of young adults with depression themselves for why they feel like this kind of patient experience work matters and what it means to them, the power of this tool. So let's go ahead and play that first montage, Peterson.
So it seems that we're having issues with video playback, at least on my side. Is that the same, Rachel, on your side?
What did you say?
I'm having an issue with that video playback from my end. Is that the same one? Because otherwise we can proceed for now, if that's okay.
Okay, so you're not able to play it. Let me know if you figure it out, and we'll go back to it. So meanwhile, go on ahead to the next slide. So I'm going to tell you a little bit about how the website works. Oh, is that going to work now?
Okay. See.
Here we go.
Okay.
Fantastic.
I really think that there's someone else out there that probably has the same issues I'm going through. And if I could help them, if this is anything worth to them, if this can stop them from doing something self-destructive, then that makes me feel better about myself. That makes me less depressed because I'm helping someone that's in the same situation as me.
If you can get a resource like this where you have people that describe their symptoms, that describe how it affects their lives, that is incredibly important. Depression is very individualistic in how it presents and why it presents. So to have another resource out there for people like me that are afraid of talking to their family or that don't have friends that can help them, this is going to be very important in their journey of control over their illness.
Sharing people's experience of what that looks like or how that feels can create a lot of compassion and understanding for people who are afflicted by depression. And that was something that I wish I would have gotten, because I think that if my friends, like through college, who had known my history of abuse and trauma, if I do believe that if they were actually really understanding of what what it felt like to go through depression, then instead of stigmatizing it, then I probably would have got treatment sooner, maybe, or I would have, and maybe I would have healed a little bit faster.
If this helps somebody out in some way, that's great. And I think that that's like pretty much what motivated me to do it, because I guess I'm just kind of tired of it being a silent issue. I would love it if people were more vocal about it, because I think that's where solutions happen. So, I know I am a private person, so this has been pretty not, something I would normally do, but I think it's good to kind of open up.
Great. Thanks, Peterson. Can we go to the next slide? So that gives you a sense from the point of view of people living with depression themselves about why it's so important to elicit and synthesize patients' experience and then amplify them using this kind of web-based platform. This is a screenshot of an instructional video that is on our website that walks you through how to actually use the website in case you don't want to just mouse around and find out yourself. But I'm not going to play the video for you. I'm going to walk you through it myself right now. Next slide. So it is categories. When we got all those interviews and we had all that information and insight about what's going on for patients, it broke down into these 5 big categories. What it's like to first find out about your diagnosis. This is true for a lot of illnesses. What it's like to live with whatever the issue is, in this case, depression. What it's like to get help and interact with professionals. How you help yourself. And then messages to others is a terrific feature. We're not going to play those today, but I encourage you to take a look at the messages to others section on the website. Next slide. All right, next slide. I walked you through that. So we're going to hone in a little bit on some of these topics. This is a screenshot of if you blow up the living with depression, there's a lot of topics there. We're going to just take a look at a couple of them today, but that's one way that we organize the data. What did people say? And we found they had a lot to say about depression in school, depression in relationships, depression in work, barriers to care, suicide issues, the positive sides of depression, etc., all the things that are listed here. Next slide. And then the website is also organized. You can see the tab on the top. Instead of looking at topics, you can look at people's profiles and get a sense for each person who we interviewed, a little bit more about their biography and their story and all of their clips in one place. Next slide. So let's dive now just for a minute into how depression feels. And as advocates, I encourage you to think not only about the barriers and obstacles and ideas that Gwen referred to, which are critically important in understanding patients' experiences, but also just the need to know what it is like. If you are speaking on behalf of others, you really have an important, or even arguably a sort of sacred duty to be able to walk in their shoes as best you can. So I'm going to show you a little bit about how depression feels as an entree to that. Next slide. Here's a little summary. These are all clips, but we don't have time to play them all. But you can see the woman on top. She talks about having a piece of her jigsaw puzzle missing. Ryan on the bottom talks about perfectionism and the way it makes it so hard for him to enjoy anything, even when he's got a real accomplishment to celebrate. Next slide. We've got people talking about never feeling as good as other people. Again, that sense of emptiness that can come with depression. Next slide. And here we're going to play another clip of Leanna, who talks about the numbness she feels.
Nice, comfortable numbness afterwards. Just like how I would think like someone who's like on hard drugs, like heroin would feel. It's just like a calm. Nothing can affect me now. Like now I can actually just go through my day like a cement block. It's not terrible. That numbness from the depression is something else in itself, honestly. The numbness is like the scariest thing that I think my friends and family have witnessed with me. It's just that literally where is she? Because that's her body, but that's not her.
Okay, next slide. And here we'll have one more view of how depression feels.
Because you're in this like mindset, you just see, like a dead field with, like a bunch of flowers like wilted, nobody there. And so, I don't know, unless, like it's not necessarily that religious, but I do feel like that your mind, like whatever's going on in your mind does like almost like change the world around you in some profound ways. So, yeah, I guess that was kind of how I looked at it, or I was like, do you just want to stare at a dead field, or do you want to like see, like an awesome forest with a bunch of people running around having a good time?
Next slide. One of our topic areas that really popped in this study was depression and its relationship to bias and disadvantage. Next slide. And again, we heard people talking about being alienated, not being able to be who they are, how culture can intervene with that, including internalized really high expectations. Next slide. People talked about sexuality and also ways of overcoming that, or what it can be like to stand strong as well as to suffer the consequences of bias. People talked about the particular challenges of being trans and how that made it harder to mitigate depression. And now we're going to hear one more clip from Tia. And remember, Peterson, we're just going to hear the first 28 seconds of this.
And did you get a diagnosis from your doctors who offered you that?
No, that's why I did not proceed with their help, because I did not want to be labeled. I did not want that in my file at all. So that's where me dealing with it myself came in, because I did not want to be labeled.
Okay, right there, we can stop that. Okay, and let's. This is a great clip, but we're not going to play it just in the interest of time. This is a young woman talking about how hard depression makes it to hold down a job, and the way it really intervenes in her capacity to work. So I'm not going to play any clips from Barriers to Care, but I wanted to highlight this for you all as advocates. We heard, next slide, a lot about how difficult access is, something many advocates focus a lot of energy on, and in particular insurance barriers and the way it intervenes in the struggle to get treatment. And then we also heard some great testimony about how when the Health Insurance Reform Act came through, people did get access that they hadn't had prior, and they had sort of a list of things that they wanted to get done now that they could actually go see some professional clinicians. Next slide. We heard about cost in the form of copays or uninsured services, and testimony about how people kind of rearrange their priorities to be able to afford some of the things that mattered most to them. And again, about the insurance through the ACA mitigating some of the access problems that had existed before. Next slide. Here's yet another clip that we are not going to play in the interest of time, but you can find it on the website. You can see that this is not a photo of a person, but of flowers. People who don't want video of themselves can opt to have audio only, or even just text on the website, and they can pick an image. So some people pick a silhouette, some people pick an image like these flowers. And Sally from our study talked about the difficulty of getting psychiatric care and the higher copays. Next slide. And then finally, I'm just going to highlight, there's so many great places on this website. I may be biased, but there's really a lot of testimony and information here. So the depression medication and treatment choices, next slide, gives some insight about people's really large variation in their experiences with and decisions about medication. So we've got people talking about wanting meds and not being able to get them. The process of talking with your clinician in order to experiment and find the right medication. Next slide. People talking about how the medication helped them tremendously, and people talking about how the medication didn't help them and why they didn't proceed with it. Next slide. And here is somebody talking about not wanting to be on medications because of concerns about being dependent on it. And I just highlight these for you again as advocates because they're ways of getting inside different positions and being able to introduce, say, these videos into conversations or forms of public testimony, using them at presentations and so on, can bring people's direct voices and experiences into the room with you, in this case on the topic of depression, but with other modules or web-based resources related to studies on other issues on, say, cancer and so forth that we will have up on our site soon. Next slide. So I want to talk just for the last few minutes that I talked before we open it up about the empowerment and engagement aspects of this work. There's ongoing communication with people who consent to tell their stories for the website, and they remain in control of their material. Even once it's up on the web, they can say, I've changed my mind, I want to take that down. And they can also, of course, disseminate it to anyone they want, and they have a copy of the audio and video files as well as the written transcript. Next slide. We've had patients or affected individuals advise in scoping the depression module and the other modules, of course, with the interviews integrated into our advisory board structure. The steering committee that I showed the slide for earlier includes 2 patient or consumer advocates. And then with dissemination and implementation work, once we've done this qualitative research study and we've got the information out there, how do we make sure that it's being used? So, Peterson, can you go up to the patient engagement and the HERN process? You're going the wrong way. You got to go back. Yeah. Oh. Now down. Next one. Okay, so next slide. The job description for the dissemination and implementation engagement that we've been working on is to be an ambassador, somebody who acts as a representative or promoter for the work. Next slide. And as with all engagement activities, having a job description is critical. And for the job of being a patient experience ambassador, we, working with some patient engaged folks to developed this job description about being really thoughtful and representing the findings of the study that are on this website, and promoting the module in various ways, and figuring out along with us how to get the word out and in what venues. Next slide. We worked on some kinds of values and norms for the work, including this willingness to learn and to give feedback to others on the team, for there to be a really good dialogue all the way around, so that we'd be learning from ambassadors would be learning from the research team, and so on. Next slide. And we put together a really in-depth training that's got a lot of these topics shown here. So critical for a patient experience ambassador model is that you speak not only for your own story, but for that collective voice that Gwen mentioned at the beginning. So we worked with people to understand the stories that were captured in the 40 interviews that are on the website, and to really sink in and absorb, and also to know some facts and stats, to be evidence-based with their ambassador role. And then we also had a lot of stuff about just what it takes to, if you've never done it, to kind of go out in public, to talk to the media, to be at conferences, to write op-eds, to be part of a speakers bureau, to tweet and use other social media to get the word out about this resource. Next slide. So here are just some photos of our folks tabling in various venues. Next slide. There was a lot of social media dissemination. That is, some of it's still going on. Next slide. One of our patient experience ambassadors was on the news and was interviewed, and this piece really drove a lot of traffic to the website, and I think the person who did it felt really good about that work. Next slide. And then we've got a summary. It's coming out very soon in the form of a toolkit about engaging patient experience ambassadors. So next slide. It's coming to hipexchange.org and should be up in the next couple of months. So look for that, or let us know if you want to be on a mailing list to get notified about it. And then finally, next slide. I just want to finish with this idea of moving from voice, next slide, to voices in the plural. I've shared with you today one way of doing that. It seems to me a critical activity for all of us as advocates. Next slide. And I encourage you to check it out at healthexperiencesUSA.org. And I just want to finish with, next slide, acknowledging a bunch of funders who have made this work possible. Next slide, and then moving to your questions. Thank you.
Thanks, Rachel. Before we get to, as I look through to see what questions might have been submitted, I have one that could get that you could maybe respond to while I look through the rest. And the question is, how do you envision we might use this powerful patient experience evidence you've gathered to influence development and use of person-centered patient and caregiver-reported outcomes as part of quality improvement efforts?
Oh, that is a great question, and one very near and dear to my heart. This work has served as the basis for a patient patient-centered quality improvement methodology called experience-based co-design. And our colleagues in the UK have done a lot of this. We're just getting going with using it here in the US now. So I invite the person who asked this question to get in touch if you're interested in moving that ahead. We're always looking for partners. But basically, the idea is to take these videos and the engagement that has given birth to them to create a montage, not dissimilar to the one I showed you at the beginning, the first video that we saw in this presentation, that is specifically about, say, care in the cancer center. And the parts of the interviews that talk about that get put together into a montage, and then there are patient experience ambassadors or patient engaged members of the QI team who work in the healthcare setting as sort of the bringers of the collective voice in the collected videos that then become the centerpiece for quality improvement activities that are implemented jointly by leaders and frontline staff and clinicians in the healthcare setting, and the ambassadors, as it were, who are bringing the video resource to make quality improvement really happen around the experience base of the people at the center of care, that is patients and families who need and use services. So that's one way to do it, but I think there's many other ways, even without the resources to mount as intentional an initiative as experience-based co-design often is. These videos can be brought in and shown, sometimes if they're not collected, say, from your cancer center, just to give an example, but at a cancer center elsewhere in the country, it kind of removes the sting and it allows everyone to sort of look at it and say, okay, this is an experience that's going on out there. Is this happening here? And if it is happening here, what can we do about it?
Thank you. And sort of back to one of the things that you touched on about how to elicit stories. How do you have any recommendations for how? And I'm asking this both for us and those who are on the line, our volunteers. Do you have recommendations for how we can elicit those stories from different people?
Yeah, that's a great question. I think we all have a responsibility to be eliciting and listening to those stories wherever we advocate. I think having an inviting stance, putting yourself in places where you're going to be talking to people whose stories you don't know as well. So finding ways, whether it's hanging out in waiting rooms or going to community meetings or putting a Craigslist ad out there saying you're looking for people. There's lots of different ways to reach people, depending on who your group is. Inviting people into conversations, I think all of that is really important. We tend sometimes as advocates, I think, to believe that we know what the patient experience is. And I try to remind myself all the time that there is no unitary patient experience. There's no single patient voice. There are always dimensions of experience that I don't know yet and that I'm not familiar with. And so we do want to know what people have in common. And I think the evidence base on this is pretty strong. A lot of us share a desire to have the care in healthcare be emphasized a lot more. But that doesn't mean that there aren't all those variations to be looking for. And in terms of how it is that you get the richness of people's stories, I think both asking people very general questions, tell me about your experience, tell me about what it's been like for you to experience depression, to have a cancer diagnosis, to live with a child who has autism. That gives us an opening when we're interacting with people, and then having some more specific questions that you might ask of people if you're working on a specific advocacy initiative that will give you a systematic way of understanding more about, say, their access barriers or their struggles with medication or their difficulties with a particular administrative or policy related aspect of their care or experience.
Thank you. And I have a few other questions that I'm going to try to summarize into two parts. And one is about regards diversity. And you said earlier, you mentioned, you talked about the importance of having diverse perspectives. And so there's, I'm curious to see, and this is a question I came to, what does diverse mean in your experience or as it relates to the research that you've done? And another question sort of related to that is, how do you address the marginalized populations that might sometimes be overlooked but are still in desperate need of services?
Yeah, so I want to make sure I understand the first part of the question was, what did the asker want to know about diversity?
It's when you talk about diverse perspectives, what experiences you've had with diversity, how you define it as it relates to your work, to your research.
Right.
But
Got it.
more generally, I think they wanted to see what your perspective is.
Yeah. So great, and I agree these are very related questions. So we try to define diversity in terms of maximum variation, which is actually a sampling methodology in qualitative research that stands at the center of the approach I was just describing. And so our team, which we try to itself make as diverse as we can, is constantly thinking, who are we missing? If we're studying depression, who have we not heard? People who live in a rural area, more racial or ethnic minorities, people who are younger, people who are older, people who are richer, people who are poorer, people who work or don't, people who have been hospitalized or who haven't, people who have a religious background or affiliation and those who don't, people who are parents and people who aren't. And you really can never be done with this. Like, I would never claim ever, and I think it's impossible, especially in U.S. society, that we've gotten all the perspectives, but we do our best to keep that at the center of our efforts. It is difficult to reach out to successfully some of the most marginalized populations. We did not, for example, successfully interview anybody from a Native American reservation, for example, yet for this module. We're still hoping that we can do it for depression. It's partly a matter of resources. It's partly a matter of access. It's partly a matter of we don't have a Native American researcher on our team yet. So it's forever a work in progress, and that's part of why I love doing webinars like this, with the hope of continuing to reach out more fulsomely, engage more people in the project of bringing the most diverse voices possible to American healthcare and to advocacy.
Great, and I'm gonna, because of time, this will be maybe the last question. Actually, we'll make it the last question. And someone was interested in knowing about if you have any resources or any thoughts about depression as it relates to seniors. And we're gonna close, so you could respond to that, and then we can wrap it up because we're at the top of the hour.
I see that. Thanks, Peterson. We did not do this yet in the United States, but if you go to healthtalk.org, that is the Oxford website out of the UK, and they have studied depression among a much larger age range than we have. That's also true for Australia. And there you will hear stories from a much more age-diverse population. If you know of any funders who would like to help us do a study of depression in older adults, we would be delighted to carry that out here in the US.
Thank you, and thank you again for everyone for joining. Thank you, Rachel. It's always a pleasure to have you. And for those of you who were joining us for the first time, again, my email, peterson.jamonge@npaf.org. If you have any questions about how you can get more involved, we have other webinars and resources on the website that you can look at and sort of get an idea of what we do and how we do it here. I will share some of the resources that we used on this presentation and the video that we could not get to play. And there will also be a survey right at the end of this session. So if you could take a minute or two and respond, that would really help with planning for the next webinar. Again, thank you, and I hope you can join us on the next webinar.